Okay, students, coming to our next video. So, as we discussed yesterday, the general approach to gynecology, the next thing which we need to see, as I explained in the previous video, was that menstrual related problems, right? So, in that, you add atypical uterine bleeding, then you add what were the other things? I told this constitute about 23 to 25% of the problems where the patient comes to you in the OPD. So this AUB is one thing, then amenorrhea, correct, then dysmenorrhea. Okay. Now, for an interesting purpose, let us start with the case. Okay, you have a woman who is 40 years of age, comes to you with heavy menstrual bleeding. How will you work up this case? And you have one more woman of more than 65 years of age, complaints of postmenopausal bleeding. How will you work up this case? So at the end of the session, you must be capable enough or competent enough to solve this scenario. Okay, now if you need to understand what is AUB, then as I explained, you should know the normal menses. So what does normal menses means? So for example, how do you think, what is the blood loss which you can expect in normal menses? That is 10 ml to 80 ml. If it's more than 80, then it is heavy menstrual bleeding. What is the duration? It is 24 to 38 days. If it's less, if it's more, what do you call? If it's less, it's called polymenorrhea. Why? Because you are having frequent menses. If it's more, then you call it as oligomenorrhea. So then how long do you think this menses can happen? Up to 1 week, as I told you. So now you know this is the normal. Now anything which is pathological is atypical uterine bleeding. Now coming to atypical uterine bleeding per se. Okay. Now as a general approach, we start with anat, physio, and patho. Okay. So what do you think can be the anatomical structures which are involved? So same. First thing, let us think locally. The cervical cause can be there. Okay. The vaginal cause can be there, like atrophic vaginitis in postmenopausal women. Then cervical cause, for example, cervical polyp and endometrial cause. All those causes can be there. Okay. And also, if in tubal cause, you can have any ectopic which can rupture. Correct. So major part lies in physiology. Why? See, this, if you consider this as uterus, when a female menstruate, the myometrium which is there should contract. Correct. That causes vasoconstriction. Then this vasoconstriction, then this is the first step. You know those steps of coagulation. The general steps. There are majorly 3 steps. First step is vasoconstriction. Second step is platelet comes and aggregates. Correct. No. Third step. This is a temporary clot. Then coagulating factors act, then forms a vibrant mesh. This is the permanent clot. If there is a pathology in either the vasoconstriction, that means if there is no proper vasoconstriction occurring, then you can have AUB. If there is problem in the temporary clot, that is platelets, you can have AUB. If there is problem in the permanent clot, that is coagulating factors, for example von Willebrand disease, then you can have AUB. So now coming to the pathology part of it. So I told again cell injury, the index of Robbins. So do you think whether a small cell injury can cause heavy menstrual bleeding? No, because you know the normal physiology, there is almost a very good balance of plasma and things. So there is a proper hemostatic mechanism per se to prevent heavy menstrual bleeding or atypical uterine bleeding. But what do you think about infection? Some infection, yes, can lead to atypical uterine bleeding. For example, in TB and all, you can have amenorrhea kind of features, infertility kind of features. I'm talking about chronic infection. Okay. Then coming to genetic causes, that is the third thing. So cell injury, then infection, then genetic. That is von Willebrand disease. Correct, no? So what do you think in von Willebrand disease? Again, they come up with every menstrual bleeding. So that is one more thing which you need to remember. Fourth is pre-malignant conditions. Okay. In pre-malignant condition, for example, in intraepithelial neoplasia of CA cervix, or also in hypoplasia of endometrium. So even in these cases, you can see AU. Then benign lesions, which are most common, leiomyoma, you can see. Correct. Then other benign causes, for example, adenomyosis and endometriosis. Correct. Then malignant part. So what do you think in malignant part? You have either CA cervix, CA endometrium, or CA ovary. So in all this case, you can see AUB. Correct. Now you know this part. So now if you understand the classification as such, that is palm coin classification, which everybody know, that is, you can divide into structural cause or non-structural cause. Correct. So what do you think is there in structural cause? Polyp, S. Next, S. Adenomyosis, leiomyoma, then malignancy. What do you think can be there in non-structural? I'm just going with the classification. Now I will link this classification to the physiopathology point of view. Then you can have coagulation factor defect, then you have ovulatory dysfunction, then iatrogenic, and not specified. See, now you should understand why there is AUB in all these cases. For example, in polyp, see what happens. This is uterus. I'm sorry for the diagram. See, there's a polyp here. See, this polyp is nothing but endometrial part of it. That means it contains gland. See, it's protruding. No, when it is protruding out, you have nothing but glands and weak blood vessels. These are friable. Okay, but this is what this friable blood vessels will lead to bleeding. Now you understood why polyp bleeds. Next, adenomyosis. What happens in adenomyosis? The same endometrium. What happens? This endometrium goes into myometrium. This causes what? Chronic inflammation kind of pain. And also, what is the problem? This myometrium cannot contract now, which was the first step of contraction. Correct. So you can have pain. Again, in leiomyoma and malignant condition, it's the same concept. That is weakening of blood vessels, friable blood tissues. Again, it leads to blood loss. So all these structural causes you should know. One, it might be related to friable blood vessels or gland hyperplasia. That will cause the atypical uterine bleeding. And in non-structural cause, see, in coagulation part 25. So here usually it will be in an young woman of 17 years or 16 years, or adolescent age group, coming to you with normal other systemic normal features but have features of epistaxis or something like that. Mostly all this von Willebrand disease are diagnosed in these cases. Then ovulation, which I will talk about it. Then iatrogenic insertion of IUCD. Okay, this causes hormone imbalance, and hormone is something which is very essential to maintain the structure. So this can also cause bleeding. Then ovulatory. Yeah, why I kept an ovulatory cycles at the last, because see, for example, this is a broader concept. See, if there is atypical uterine bleeding, then you can classify it as if bleeding occurs due to ovulatory cause, anovulatory cause, or anatomical causes. Anatomical causes I discussed: fibroid, polyp, all those things. So now you should understand why there is a classification like this. See, for example, in anovulation, there is estrogen excess. So when you bleed here, no, you will not have pain. So dysmenorrhea is not a feature of anovulatory AUB. But what happens in ovulation? There is progesterone. The balance between progesterone and prostaglandin is one which determines whether you will have pain. Here there is some abnormality, so in ovulatory cycles you will have pain. See, understand the concept. When the patient, as I have discussed in the earlier video, ovulatory cycles will come up with pain, and in adenomyosis also you will have inflammation kind of features, so they will come up with pain. See, that is why lower abdominal pain constitutes almost 50% of the case. Got it? So now you know why in AUB, why in ovulatory or non-ovulatory cycle, how do you differentiate it? That is the first thing. And why you will have bleeding. Again, hormone imbalance. Here there is no progesterone, so endometrium, due to unopposed action of estrogen, at one day it has to shed, so you will have bleeding. But here it's a part of normal process. But here, no, in AUB it's mostly anovulatory cause, which we will discuss later. So now you know what are the structural and non-structural causes. So now we have a idea of how to go about it. So now you know why does it happen. In our next video we'll continue this and how to approach a case. So that first case scenario which I will discuss, we'll discuss in next video, so that you know what to study now and where to concentrate. So coming to the gist of the whole video, sit back, see. First thing is, we discussed what is the normal physiology and normal in menstrual cycle. That is a normal of 10 to 80 ml of blood which has to be menstruated. If it's more, it's heavy menstrual bleeding. And the normal duration of a menstrual cycle is 24 to 38 days. If it's less, it's polymenorrhea because it's occurring more. If it's more, then oligomenorrhea. Then if it's more than 1 week, then it's something pathological. Then we discussed about anat, physio and patho, the general approach which I taught you in the earlier video. There we identified what can causes bleeding, the physio part of it, and what are the steps in coagulation pathway. I have not discussed about intrinsic and extrinsic because that is something which is very basic, which you should know. Otherwise we'll just study physio, patho, anat, but that is not the core concept of the video. In the next video we'll discuss about all the condition and also the pathology, where in which conditions you can see heavy menstrual bleeding. And also I discussed the classification as such, the palm coin classification, and I gave a substantial explanation why every condition will lead to bleeding. Correct? So in our next video we'll discuss why and how do we approach a case of AUB when you are in OPD or when you are in a primary healthcare setup or in a tertiary healthcare setup, and also the investigation part in the next video. Okay, thank you.